All right, thanks so much. And thanks to everybody for joining us on this session today on structural racism and genetics, consequences and plans for the future. We have 3 speakers today. As I indicated earlier, we have CME available. At the end of this, Alyssa's going to, we're going to go back to Alyssa and kind of talk about what we learned today. So our first speaker is Dr. Gold. She's an MD, PhD, and a postdoctoral research fellow at the Children's Hospital of Philadelphia. She received her MD, PhD from Thomas Jefferson University in Philadelphia. And she also has received an ACMG Foundation Award for Healthcare Transition. And she's developing a curriculum on diversity and inclusion, and she's going to talk to us about some of that today. Our second speaker is Barbara Harrison. She's well known to NIMAC. She's a genetic counselor in the DC area. She's lead of the team lead for DC. She's also certified by the American Board of Genetic Counselors and serves on its board of directors and an assistant professor at Howard University. And she's also the co-founder of the Golden, which is Genetics Opportunities, Learning, Development, and Empowerment Network, which is dedicated to increasing the number of Black genetic counselors and doing mentoring and getting Black students interested in the field. Our last speaker is Grace Ann Fasaye. She's a senior genetic counselor at the National Cancer Institute, and she provides genetic support and serves as an associate investigator on natural history and surveillance protocols for cancer patients. She's has been a research coordinator for several genetic counseling projects, and she's also a co-founder of the Golden program. So welcome to our speakers and everyone today, and I will turn it over to Dr. Gold.
Thank you for having me this morning. I'm really excited to be talking about this topic because it's very important and it has direct implications for how we interact with patients and their families and kind of how we approach genetics at really every level, from what's happening at the lab level to what's happening in the interpretation level to what's happening at the clinic level. And I think that the more that we talk about it, the more solutions hopefully we can find to some of the issues we have in structural racism and genetics. How I'm going to go through things today is to give a little bit of the history about why genetics in particular, out of all of the fields of medicine, really needs to address kind of the history of racial pseudoscience that is foundational in the field, and then share some data from the University of Pennsylvania adult genetics clinic, where we've kind of looked at what type of systemic barriers there are to receiving genetics care, and then talk about how we've kind of built a curriculum to examine what we're doing at the Children's Hospital Philadelphia and the University of Pennsylvania to address these issues. And so to start, I'm just gonna start with some poll questions to kind of get the sense of what everyone in the audience feels about these topics. And so there are 4 questions here. I'm concerned about structural racism and genetics, and you can use any of these options, agree to disagree. Learning about structural racism and genetics is important. There is a need for education on structural racism that is specifically dedicated to medical genetics, and again, agree to disagree. And then knowledge on structural racism in clinical genetics will change my personal clinical or lab practice.
So those results are coming in. I'll give some more time so more people can answer here. And it looks like our numbers are stabilizing. So I'm going to close the poll in 5, 4, 3, 2, 1. And there are the results.
And so for the first question, I'm concerned about structural racism in genetics. You can see that most people here strongly agree in some form. Learning about structural racism in genetics is important. Again, there's a lot of agreement here, and I know that people have chosen to come to the session, so hopefully there's agreement in this matter. And then again, agree that would be interesting to hear from the 3% that strongly disagree. And we'll have time to talk about that later, that don't think that we need to specifically talk about it in medical genetics. And then kind of a little bit across the board in terms of that, whether knowledge on structural racism will change your practice in clinical. And so this is, these were some questions that we also asked our fellow trainees in the curriculum that we've been developing. And so they all thought that both that learning structural, that I think 88% thought that learning about structural racism and genetics is important and that it would change their clinical practice. And so these kind of track along with what the rest of the audience here thinks. So the reason that we need to talk about structural racism and genetics specifically is because of the history of eugenics. And eugenics started to develop really shortly after the idea of genetics and natural selection and survival of the fittest was described by Charles Darwin. So he came back from the Galapagos, he wrote up his inventions, and within the next 10 years, people were talking about, okay, well, how can we apply natural selection to the human population? And so this was a common thought where we are using all of these branches of science to put them together to make sure that we're having humans evolve in the best possible way to find a way to do natural selection. And so this, you know, in some ways, this didn't sound like a bad thing. It was similar to how the founders of eugenics compared it to how you would breed cattle. You would want cattle to have the best possible outcome, the most meat or the most dairy, and you would put your breeds together that you knew were going to accomplish that. And so there was this idea of positive eugenics. So if you have good offspring, then you can improve the gene pool and you can make sure that you're going to breed to pair people that have kind of good traits together and they're going to make better people. And this it's very classist. So people that were of the highest social class thought that they were also of the best stock and they were going to make sure that everything stayed within their class. And it's one thing to maybe do it on the positive side. There are still cultures that do matchmaking. There are cultures that do matchmaking using carrier screening as a background. But the negative side is really where the issue comes in. And because that negative side is really predominant in how we view eugenics.
Dr. Gold, there's a request from the interpreters just to slow down a little bit so they can keep up. Thank you.
Okay. So the negative side of eugenics is problematic. And here, instead of pairing people that were thought to have good qualities together, the negative eugenics means discouraging or preventing those that are thought to be unfit. And so how they did that was by preventing marriage of people that were considered unfit, preventing racial mixing, institutionalization, sterilization and castration, immigration quotas. So for example, these were kind of the basis of a lot of the immigration quotas in the United States in the early 20th century. And then kind of making sure that reproduction did not happen. And so this is really reflected in a lot of the prominent genetic institutions in America. And this is the history of a lot of the first genetic institutions in America. Cold Spring Harbor, which is known for kind of being the birthplace of a lot of genetics in the US, was started as an office of eugenics and was used to track good traits and bad traits among people. Margaret Sanger, who we think of as the mother of birth control, developed clinics to keep the people that she considered unfit from reproducing. And that is kind of her legacy is very mixed there, because while birth control has been really helpful for allowing reproductive options for many people, there's also a history of people being put on birth control that didn't want to be put on birth control. Buck v. Bell is the Supreme Court case from the 1930s that allowed institutions to continue to sterilize people without their consent. So this was Caroline Buck was the third generation imbecile, as was put in the court case, who was institutionalized, and the institution wanted to sterilize her because of that family history. And I think when she got out of that institution, at some point, she was actually found to have normal intelligence, and it was very much from her environment and upbringing. But it allowed sterilization to occur in the United States without consent, really up through the 1990s, and in some prison systems like the California prison system through the 2010s. So negative eugenics has been in action really since we started doing eugenics until very recently. And then what was interesting in the ASHG position paper that they just recently released in the last 6 months was that they realized that a lot of the leadership from the original founders of the ASHG had ideas that were rooted in negative eugenics. So people like Dr. Kalman, who Kalman syndrome is named after, was using what he was doing in genetics to kind of make sure that certain people were not reproducing. And even more of a connection to what we do now in medical genetics, to that history of genetics, is Francis Galton and his legacy. Francis Galton was considered the father of eugenics, but he really is very much the father of clinical genetics as well. And so he invented standard deviations and variants, so that was from his lab. And the way that he did this was by creating the dysmorphology exam. And he would do the dysmorphology exam on hundreds of people and kind of see where head size plotted and where nose size plotted and where eye space plotted. And through that, he was able to come up with what standard deviation was and what variance was. And we have not changed that much from when Francis Galton first invented the dysmorphology exam. This slide is a card from his laboratory. And kind of, if you think about what we do when we do an exam on patients and the medical genetics practice versus what Dr. Galton was doing or Mr. Galton was doing is not that different. So he was measuring head length, he was measuring head circumference, he was looking at height and wingspan, weight. He was the father of dermatoglyphics. So he was the first person who did a scientific study of fingerprinting. Which as a trainee of Dr. Elaine Zakai in Philadelphia, we are still doing that for all of our patients. And so these qualities of what he considered to be exam of normal human variation are still have been passed down through generations and are still in use today all of the time. The problem is that Dr. Galton used his exams for characterization and for classification, and hopefully is something that we are getting away from in modern clinical genetics. So this is what Francis Galton would do after he kind of put exams together. And he would say, these are the patients that come from a good family, that come from of good stock, of good upbringing. And these are the ones that are criminal or have kind of, these are the features that you would see in an imbecile or someone that should not be allowed to breed. And you can see this here, where he has, these faces as representative of the criminality. And so he would take the dysmorphology exam and then use it to classify people. And this is the issue kind of that has been really at the heart of genetics since its beginning is, can we categorize people? And then can we put those categories into a hierarchy? And when we're getting into discussion of hierarchies and how people look, that it becomes very problematic. And one of the reasons that it's problematic is because what we talk about in genetics and what we publish about in genetics and what we kind of are teaching about in genetics becomes co-opted. And even if we don't intend for that interpretation to happen, it's out of our control kind of what sits in the public sphere, especially with how discussions happen in social media, on the internet, and kind of get taken like that. And so some examples of how genetics has been used to kind of promote white supremacy is amongst milk drinking. So lactose intolerance is thought to be something that is highly prevalent in the Ashkenazi Jewish community and the Asian community. And so if you are of Northern European ancestry, you should be able to drink tons of milk without an issue. And so you can see some groups of people here on this side who are demonstrating their Northern European ancestry by chugging milk. Another interesting way that genetics has been co-opted is in the rehabilitation of the Neanderthal image. So even 25 years ago, that was kind of used as a derogatory term. So people would say, like, considering Neanderthals to be less intelligent and less developed, and would kind of use it in those ways, both in how in advertising and kind of pop culture ways. In the last 20 years, since ancestry testing has been more common, people that are of Northern European ancestry have found that they share a decent amount of Neanderthal DNA. So 5 to 10% of Northern European ancestry DNA is from Neanderthal stock. And so now there's a new found appreciation of Neanderthal skills and their art and how developed they were, which wasn't the case before that combination of DNA was seen. And then most importantly is that there have been many situations where intelligence has been linked to genetics and genetics hierarchies. And so the bell curve came out in the 70s. It was really the first piece of work that said that some people are going to be at the top of the bell curve and some people are going to be at the bottom of the bell curve, and these types of people are more likely to be at the bottom of the bell curve. We are seeing a reemergence of linking genetic ancestry to intelligence these days, as there is more interest in striking down affirmative action. And so the idea is that if some people are going to be at the bottom of the bell curve and we can identify who those people are based on their ancestry, then no amount of help in terms of getting them into higher education is going to change that. This is just who they are. And so this is a way where what we are doing in genetics, where we're kind of describing people and categorizing people, is being used in ways that we are not intending it to be. And so it's really important to think about how we are talking about genetic outcomes and how we are grouping people. And so we actually looked at if there were race-based disparities in our adult genetics clinic. Previous work has been done in pediatrics clinics and then in certain fields of genetics, so specifically cancer genetics, to look at how we are approaching genetic evaluation and testing. But nothing has really been done in a general adult population. And general adult genetics is interesting because it's less visible, there's less exposure, and it really is very much dependent on other provider or patient-driven referral to get in. And so what we first did was look at the population of underrepresented minorities. So Black patients and Latino patients, which you can see in this color blue, and then these light yellow and green. And we looked at the population of these patients, both in the city of Philadelphia, where white people are only about 40% of the city's population. And we compared that to the general population of the University of Pennsylvania health system, where white patients are about 65%, and then looked at other subspecialty clinics. So the endocrinology and the cardiology clinic both really model what you see in the general UPHS health system. So about 65% of their patients are white, and then 25 to 35% of their patients are underrepresented minorities, so Black and Latino ancestry. However, when you look at the genetics clinic, which you can see here, all of a sudden it goes up to show that about 80% of our patients are white, and only about 10% of our patients are of underrepresented minority population of ancestry. And then this is always, even just looking at this data and what we were talking about earlier, this is already a little bit problematic because it's only self-reported race. And so that's not necessarily true ancestry. And that's kind of an issue with genetic kind of classification in general, but this is self-reported race. And so something is happening where patients are either not being referred to genetics at the same rate that they're being referred to endocrinology or cardiology clinic, or patients are not coming to these appointments because they don't think it's as important as seeing their endocrinologist. So getting their diabetes controlled or getting their heart, dealing with any types of problems with their heart. And so there is some breakdown in education. What is particularly interesting, though, is that when we look at our testing rates, we show that we are sending genetic testing much more frequently, significantly more frequently, for Black and Latino patients. So the patients that are getting to genetics clinic, even though there are less of them, they are more likely to have signs that are significant for potential genetic diagnoses. And then what's particularly more interesting is that while it's not significant, there is some increased likelihood in positive testing, and there is no increased likelihood of a non-diagnostic testing, so a variant of an unknown significance. This is very interesting in light of all of the other really reports that are out there that show that patients of Black and Latino ancestry are significantly less likely to get a positive result and are significantly more likely to get a variant of unknown significance. And this has been shown in carrier screening. The group has done carrier panels and FHQCs that target Latino patients, and only 2% of them received a positive result. It's been done in cardiomyopathy, where you're significantly more likely to receive a non-diagnostic result if you are of Black ancestry. It's done in pediatric sensory neural hearing loss clinics, where you're significantly less likely to receive a positive result. So our patients are not less likely to receive a positive result, and they are receiving positive results not infrequently. So to us, this means that we're really seeing the tip of the iceberg out there in the underrepresented minority community. We're seeing patients that have kind of slam dunk findings of genetic disease, because it's not like the interpretation's better or that we found new variants that are helping remove these variants of unknown significance. So there needs to be some education component that's going to get these patients to clinic, both on the provider side, that's telling them when they should come to clinic, and then on the patient side, which is enforcing the importance of a genetics evaluation and why you're going to see change your medical management based on your genetics, based on a genetic diagnosis. And so as part of that, we have received a Diversity Endowment Award from the Children's Hospital of Philadelphia to work on a genetics curriculum. And we have done this through kind of a multimodal intervention, just based on the size of the genetics department at CHOP Penn, and kind of making sure that everyone feels included. And so this has included knowledge checks. So we've planned to schedule grand rounds, as well as lectures that are specifically targeted to our trainees. And we have trainees in medical genetics, in medical and clinical biochemical genetics, as well as lab genetics. There has been some personal reflection where we've had book clubs where we have read a book and discussed what we've learned, as well as Ballant Group, which is it's a way to talk about patient-provider interactions and relationships. It was developed generally for family medicine programs, where you might have a challenging patient who doesn't listen to your recommendations. And the problem is not to solve their diabetes, but kind of to solve how you handle these conversations. What do you do with the patient that you least look forward to seeing when they're on your schedule? And then amongst the fellows, we've talked about how we can change our personal practice, and then what type of quality improvement projects we can develop at CHOP to kind of think about these issues. So this is what the timeline has looked at. We have had a session really kind of every few months, either been a grand rounds or a fellows didactics, and then book club and the Ballant Group. And so the fellows, before they started the curriculum, received a pretest just to kind of check where their knowledge was and then check where the attitudes were. The attitudes were very much the questions that you saw at the beginning, but here are some of the examples of the pretest. And I was hoping that we could take some of these pretest questions to see how your knowledge is.
Dr. Gold, just another reminder to speak slowly for the interpreters. Thank you. Responses are coming in, and so I'll give some time for that. All right, it looks like things are slowing down. I'm going to close the poll in about 5 seconds here. And 3, 2, 1.
Okay, so So historically, the term Caucasian has described people from the following regions. And so I think you guys hit on a lot of answers here, and kind of the issue with using the term Caucasian and why this is something that actually the fellows communicated, where they said, what we would want to see most importantly is that older attendings who are not as kind of invested in these changes, just to no one use the word Caucasian. So Caucasian historically has described everyone from Northern Europe to India. So people from Persian industry, everyone from the Middle East period, even people from North Africa have been described as Caucasian in the past. So really, you got a lot of these, but it's really a very broad term. And then how many self-reported Black individuals were enrolled in the first cohort of the Human Genome Project? And then 50% of you got that right. And the answer is 0. And so that is just something to think about when we kind of look at where we've started and where we're going. So the pretest average knowledge was amongst the fellows was 50%, which is pretty good. 88% felt that addressing structural racism is very important, and 100% thought that formalized learning would greatly impact our clinical practice. We've completed our Grand Rounds series, and this was a really interesting series to plan because the attendees of our Grand Rounds really span the breadth of the genetics community. So it's the clinical staff, so the genetic counselors, the dietitians, the physicians, and the trainees. There's also a genetic counseling school at Penn that comes, and all of the genetic counselors involved that are embedded kind of in various subspecialty clinics at Penn and CHOP come to Grand Rounds. And then there's a full lab division. And so we were hoping to kind of get speakers that would really kind of address each of these communities so that everybody would feel invested in thinking about these topics. And so Dr. Dasgupta came for the first talk. She's a professor out at BU who specializes in diversity, equity, and inclusion in genetics, and is the past president of the APHMG. Ambrose Wonkum is fantastic, straddling both the clinical side and the lab side, and really increasing how we think about diversity in genetics, both on the genomic level and in the clinical level. Aishwarya Arjunan is a genetic counselor who has done a lot of work in the reproductive space and spoke about her experience there. And then Dr. Latrice Landry is really working on health systems and how genomes and health systems can be used to break down some of these structural barriers. We read Superior by Angela Sani that looks at kind of how genetics and hierarchy have been used throughout the last 200 years. And then the fellows came up with the trainees came up with a QI project that they're hoping to get off the ground in the next year, where they're examining delays in whole exome sequencing for non-native English speakers. So are patients that are native English speakers getting their results faster? Are they getting things processed faster? And then kind of where these delays are so that we can help them. And so to end, I just wanted everyone to think about what topics they want to include in a curriculum on structural racism for your own communities, and what you think would be helpful to have. And we could kind of have a short discussion about that before. So when I see the one question about hypermobile EDS, so while everyone is sharing their thoughts, even when we removed the hypermobile EDS population, the referral rates were very similar. So it's there is some impact of that population, but it's not as much as you think it would be. So some topics that are rolling in: barriers to getting in the door, agree access is such an issue. And I think that is related to workforce. So where your genetics clinics are located are an issue. Health literacy. We talk about a lot of complicated topics in genetics, and I think it can be very challenging to kind of make sure that everyone understands that. the history of dysmorphology is a great issue, especially there's been a really good series about kind of expanding the dysmorphology atlases. I don't think it's been reflected yet in things like Smith, but it's at least people are getting their pictures out there, and there is the online atlas that is more diverse. These are all fantastic. I think this comment from Leslie Johnson about biracial, multi-ethnic backgrounds is really challenging because of how, especially on how we look at clinical research. I'm more of a clinical researcher, and there's not room in your electronic health record to really describe ancestry as more than just one choice. So, and I think a lot of these, kind of to segue to our next speakers, a lot of the issues that everyone is bringing up can be helped by kind of developing the workforce more and having more people that are in genetics kind of have more concordance with the populations that we're seeing. How do we reach out to minority populations? How do we get them to trust us? And I think that I'll turn it over to our next speakers so that they can kind of share their experience with getting to that.
Thank you, Dr. Gold. That was a great presentation. And I know in the beginning they said the order would be Dr. Gold, then Barb, then me, but I'm actually going second, and then Barb will follow up. So I'm going to share my screen and keep all of the comments coming in the chat. They're very interesting. And some of them relate to what I'm going to be discussing next. Okay. So you can see my screen
That looks
and
good.
my
Yes.
slides. Okay,
Yeah.
Great. All right. So my name is Grace. I am going to be talking about another angle of structural racism, specifically focusing on the diversity of the clinical genetics workforce, and talking about a program that I co-founded with Barbara Harrison called GOLDEN, which stands for the Genetics Opportunity, Learning, Development, and Empowerment Network. So Barb is my co-presenter. We don't have any financial disclosures, but as a federal employee, I must state that my views or opinions are my own and don't necessarily reflect those of the National Institutes of Health where I work. So from the responses from the initial poll questions, it was nice to see and encouraging to know that this audience sees the importance of increasing awareness about structural racism and its influence on the field of clinical genetics. I'm going to provide some context about the motivation to develop GOLDEN by first discussing the impact of structural racism on provider diversity using the training of Black physicians as an example. And, as Dr. Gold was saying, there's so many different levels to structural racism. And if we want to dismantle it, we have to acknowledge the damages that it's done on every level, including the community level, the institutional level, and the intrapersonal levels. At the structural level, the truth about medical education is that because of legal racist policies in this country, in the 1830s, Dr. James McCune Smith was the first Black person to practice medicine in the United States, but he didn't train here. He trained overseas in Scotland because medical schools did not admit Black students. A pivotal event in the history of the education of Black physicians was in 1910, when Abraham Flexner published a report intended to create academic standards for institutions that provided physician training. Unfortunately, the document included discriminatory language devaluing Black physicians, and standards were put in place that ensured that underfunded Black medical schools could not meet the academic requirements. In 1910, there were 7 medical schools at historically Black institutions that trained the majority of Black physicians. However, the Flexner report led to the eventual closure of 5 Black medical schools. And this significantly stifled the training of Black physicians and contributed to the plateauing of the Black physician workforce. And we know this can have a big impact on the health of communities, because many studies have shown that providers from minority backgrounds are more likely to provide services in underserved communities. Black medical schools have contributed a large percentage of physicians from all types of minority, ethnic and racial backgrounds who are currently practicing. So on the institutional level, as a result of more than a century of limited growth of Black medical institutions, most minority physicians and allied health professionals, including clinical geneticists, and genetic counselors, are trained at predominantly white institutions. If we think about the inter and interpersonal level, minority students trained at these institutions report experiences of microaggressions and marginalization, which contributes to feelings of social cultural isolation, internalized racism, and imposter syndrome. And Barb will address some of this in her portion of the talk. And so what we know and what we've heard several times throughout this conference is that providers with expertise in genetics from underrepresented backgrounds are needed to reduce genetics health disparities because they understand the culture, they speak the language, they can build trust with underserved patients. And so they widen access to genetic services. But we know that there's a striking lack of diversity in the genetics workforce. Only 21% of physician geneticists identify as a person of color. And this slide specifically is looking at the genetic counseling profession, and the numbers are even lower. Only 11% identify as a person of color. As the graph shows, the low diversity of the genetic counseling profession has persisted for decades. And although there have been strides in increasing the number of genetic counselors who identify as Asian, what has been consistent over the last 30 years is that only 1% to 2% of genetic counselors identify as Black, which we know is overwhelmingly disproportionate to the 13% who identify as Black in the US population. So, as genetics becomes increasingly woven into all aspects of healthcare, we cannot achieve health equity for Black and other underserved patient populations without expanding the racial and ethnic diversity of the genetics workforce. So with that background knowledge, I'm going to talk about Golden and its origin story and how it started. So Barbara and I formed a bond over 20 years ago when I was a student at the Hopkins Genetic Counseling Program, and she was my clinical supervisor during my rotation at Howard University Hospital. And since the beginning of our friendship, we've shared that we really want to do something to make a change and increase the diversity of the genetic counseling profession. We both have been doing various things, but we really wanted to take an initiative and do something together regarding the diversity and increasing the number of Black genetic counselors. There was a time where these genetic counseling awareness camps were popping up, and they still exist, like day camps, to have career seekers learn more about the field of genetic counselors. And so we thought of creating something similar, but conducting them at HBCUs, historically Black colleges and universities. With our busy schedules, that just didn't come to fruition as quickly as we wanted it to. And then we know, everything changed in 2020. It's a very traumatic year for a lot of us because of the murder of George Floyd. the COVID-19 pandemic, the Black Lives Matter protests. There was just an intersection of various events that made us take pause and think about our priorities and really focus on revitalizing some of our projects and things that had gone by the wayside. So Barbara is an integral member of NIMAC's DC team, and she shared our day camp idea with NIMAC leadership, which began the collaboration that led to the creation of Golden. And since I have a good number of people in the audience, I want to take this time to thank NIMAC. Just express deep gratitude for all they've done. And I especially want to point out Luba, Alyssa, and Pat, because they've been extremely supportive of Golden. So once our collaboration with NIMAC was solidified, Barbara and I hit the ground running, and we at this point have expanded way beyond the day camp idea. And Golden has become an interactive mentoring and support network. So we're familiar with the African proverb, it takes a village, which is typically used when referring to raising a child, but it also holds true when developing a passion project. Barbara and I were really intentional in assembling a group of talented individuals to contribute to the vision of Golden. We sought out experts who were part of the culture and who understood and even experienced, in many cases, the barriers we were seeking to overcome. So one of the first experts that we tapped was Tokiwa here. She is a STEM education consultant, and she helped us strategize how to build our program in a way that would be accessible to our intended audience. And she really stressed the importance of ongoing evaluation of our program. And then she linked us to Cagney, who helped us create our evaluation instruments. Erica and Tiffany helped to build the foundation of Golden. Erica is very focused on our social media campaigns. And Tiffany really kept us laser focused on our mission. We recently brought on Tatiana, who is a new grad. She's a genetic counselor, and she's leading our efforts in organizing presentations about about genetic counseling to students at HBCUs. And we've also had two amazing interns, Louise and Ariel. Louise was our first one, and she went on to, she's now at Sarah Lawrence College. And Ariel, we just found out last week, she matched and she will be attending Sarah Lawrence also. And the two of them have been really helpful in keeping our goals focused on the needs of our mentees and prospective students. So everyone that I just talked about and other genetic counselors who are involved in Golden are helping us to achieve our short-term goals of building a community amongst for potential genetic counseling students, which we call our mentees. We also, in general, want to engage the Black community more broadly and increase their awareness of genetic counseling as a field and just overall of the clinical services. We want to improve writing skills of our mentees, increase awareness of internships, and increase access to professional networks, and support students through the training experience, which wasn't one of our initial goals, but we realized there was a need, and Barb's going to talk more about that. Golden's long-term goals are to increase the number of Black students applying to genetic counseling graduate programs who get accepted and then successfully complete the programs, with the ultimate goal of increasing the number of Black genetic counselors and retaining them in the field. So Barbara and I had a general idea of what we wanted to accomplish, but we worked with NIMAC's evaluation team, Melissa and Oksana, to really make our goals crystal clear. They helped us with that and think through how our resources and activities lead to measurable outcomes. And they will be presenting later today also. Our educational activities, I've already talked about, so I'm gonna go through this pretty quickly. We expanded beyond HBCUs. We also go to high schools. and other universities that have a large minority population of students to give lectures about genetic counseling. We have monthly group mentoring meetings. We do it virtually, and that helps us reach mentees from all over the country. We even have some people from overseas who are a part of Golden. And then we really are using social media because we know college students, high school students, other career seekers are very active on social media. So here are our social media handles, and they will also be dropped in the chat. So you could feel free to follow us on social media. This is a clip of our YouTube page, and we really wanted to make sure that we put the visibility of Black genetic counselors out there on the internet. So if a Black career seeker is looking up genetic counseling, that they'll see themselves represented. They'll see genetic counselors thriving in the field who look like them. It'll be a more welcoming experience for them. As far as additional activities to prepare students who know they want to apply, we have mock interviews, practice mock interview sessions. We have a writing specialist who provides one-on-one tutoring, especially for their personal statements for their applications. And we share resources for obtaining internships related to genetic counseling. And we've been successful in helping some of our mentees secure internships. So I am going to poll the audience and ask a question about any initiatives that you're involved in. You know, we're all getting more and more busy and accepting the challenge of adding on being involved in DEI and other types of activities. So you can read through the list of questions here and submit your answers.
We do have those results coming in. I'll give a little more time
Mm-hmm.
to give more people a chance to answer.
Okay, great.
All right, it looks like participation slowing down a little bit. So I'm going to
Mhm.
close the poll here in 5, 4, 3, 2, 1. And there are those results.
Okay. So it seems that the highest answer here is that, no, I'm not involved, but I would like to be in the future. And so because of that and that desire that we know some people have, but perhaps, you know, their job or their busy life doesn't allow it, we are going to invite an opportunity to collaborate with existing initiatives at the end of Barb's portion of the talk. And then I do see that people are involved at their job, which is wonderful that there are jobs and workplaces that are supporting these types of initiatives. So I'm going to turn it over to Barb. She's going to talk about some outcomes for Golden and some future directions. Thank you.
Sure. Yep. So thank you. Good morning, everyone. We're in that last half hour of the morning. So thank you for, staying with us for this session. We really appreciate all of the interest. And so what I want to do is we kind of close out here is just talk about some of the specific activities that Golden has undergone to increase the interest, and as we said, our end goal of increasing the number of Black genetic counselors. So Grace mentioned, kind of an overview of the different activities that we do. And so as a result, these have been some of our outcomes. So one is that we've had over 900 views to our videos that we've had on the YouTube page, and that's mirrored as well by our engagement on social media. We understand that, the generation that's coming up now really gets their information through TikTok, through Instagram. And so it was really important for us to invest effort in our social media, and YouTube being one of those. And so again, we just have to give some kudos to Erica Price, who really has been the brainchild behind much of that. Now, Grace also mentioned that we not only go to HBCUs, which are, of course, historically Black colleges and universities. We've been focusing on ones here in the NIMAC region, but we've also engaged some predominantly white institutions, and that's been mostly even from my own experience. I went to Maryland College Park, and no, there's a significant number of, African-American students there who, and we know that, that's a resource as well for folks that may become genetic counselors and may want to become genetic counselors. And, several papers have come out talking about the pipeline into STEM careers and how it starts in high school. And so we also appreciate that identifying high school students who might be thinking about working in the health field, and educating them about the availability of genetic counseling as a career is also critical in increasing those numbers in the end. And so we've haven't done as much of this, but certainly have had some events at high schools that are focused on increasing the awareness of genetic counseling. So we've done some of those over these past few years, but our main efforts are really on our mentees. So once someone signs up, whether they're a high school student, undergrad, post-baccalaureate, midlife, wherever they are in that journey, we invite them to become mentees. And so once they become mentees, they get direct communication about our monthly events that we have. And so these monthly events are open to all of our mentees. We do focus them on certain topics. So we've had case presentations by Black genetic counselors or Black genetic counseling students. And often those cases will focus on ones that involve issues around diversity and inclusion, whether it's, an interaction that happened between the counselor and the patient, or a family issue, or kind of cultural issue that the patient was experiencing that impacted the genetic counseling session, whether it was an issue around access, all of those things we want to highlight those as we engage people in thinking about genetic counseling. And of course, it leads to, significant interest. So we have our case conferences, we have individuals come and talk about the interview process. We know that applying for and getting into genetic counseling programs is a challenge. It's a highly selective process. And so we are trying to arm our mentees with what they need to be able to be successful in that portion of their journey. And so we have students come and reflect on their experiences going through the process. We have genetic counselors come in and provide some expertise. We even do mock interviews where we have a genetic counseling student and Black genetic counselor set up time to do a mock interview for mentees that are going through or preparing to go through their own interview process as they apply. So that has been one of our kind of more popular and I think most effective activities that we do through Golden. So we have many mentees in our database, and they engage on different levels. Some just, kind of see our information that we put out. We, usually get a critical mass that come to our events. And again, it varies depending on the topic that we're talking about. We've engaged around 40 Black genetic counselors who serve as mentors, again, whether they're coming to talk at one of our mentee sessions or whether they're acting as a interviewer for a mock process. And so they, along with our Black student members, really provide a great background for us to depend on as we go through these activities and try to engage our mentees. So we can't necessarily, the fruits of our efforts are here. We know that there are many other things that are influencing the number of prospective genetic counselors getting into programs, but this is the match data. And so, certainly over the years, the number of prospective students of color that are matching has increased. But I want to draw your attention to the purple band, which is the band for African Americans. And so you can see that in and of itself has remained relatively stable. We kind of saw an uptick in 2021, but then it kind of came back down in 2022. And so we still, and although we are excited about the overall trend here, we still very much see the purpose of Golden and the need for Golden to increase the number of Black genetic counselors. But as our mentees, go through their process and they match, we celebrate them. And so we, again, use our social media outlets to get them out there, use this as inspiration for upcoming prospective genetic counselors to see that, yes, you can achieve this. Yes, you can match into programs and you can become a successful genetic counselor. But in the midst of this, we also support our mentees that do not match, because we know that, the match rate is around 20 to 25%. It is a, very competitive process. And so we encourage those that do not match and, let them know that there are many very successful genetic counselors that had to apply to programs 2 and sometimes 3 times. So that's okay. And we try to arm them with we try to help them through that process of reflection to see what is it more that they need, whether it's more shadowing experience or, maybe presenting themselves in a way that demonstrates the experience that they have and how it relates to genetic counseling, so that they can get through the application process successfully. Now, one thing that we recognized, and Grace mentioned, this was not something that was originally in our minds, but quickly became apparent, was that once our mentees were getting into genetic counseling programs, that inclusion and belonging then became the issue. Even I reflect on a quote that I can't say verbatim by Dr. Martin Luther King, but he talked about, even his own hesitation when he was encouraging people, encouraging desegregation was, if I'm telling my people to go into a burning house, that's not very helpful, right? So you want to make sure that where we wanted to make sure that where our mentees were ending up was supportive. And if it wasn't supportive, that we were offering some assistance in that. And so some of the things you see on this slide were things that we were really literally seeing with our mentees, that they were bearing this brunt of having to represent the whole Black race because they were often the only Black student, and sometimes the first Black student at a program. And just charting those waters is very difficult. And, I know that I could attest to that through my own experience and Grace as well. We know that it's hard to be in that position. And, this is something we were experiencing in the 90s, into the early 2000s. And so to hear, 22 and 23 years later that these experiences were still happening, the microaggressions, the, feeling like you're not enough, again, this pressure of having to speak for your race. And then, other ones that, other microaggressions that have been documented quite well in the second bullet here, getting comments that maybe you don't belong in the United States, or assumptions that you weren't born in the United States, being confused with other classmates that were of color, just because people aren't really paying enough attention to recognize that there's 2 different Black students in this program and not just one. And then intrusive questions, or questions again based on assumption, that made students feel, or can make a student feel very uncomfortable when they are the only one. And so this is, we can kind of see it in our eyes that this is affecting the mental health of our students as they're going through programs. And so we wanted to be able to provide some support around that. So we actually have a therapist that we offer a few sessions, group sessions over the semester, where these Black students or mentees can come together and share those experiences, because that can help to know that you're not alone, and even share with some strategies of how to deal with that stress. And so why is this an issue? Why does this continue to be an issue? And so we just wanted to highlight again some work that's been done to explain why inclusion and belonging is still an issue within the genetic counseling field. And so even though organizations like the National Society of Genetic Counselors has done some work as far as trying to identify, over the years have done some work to try to tackle this issue, often not just the NSGC efforts, but other efforts as well, really were unsupported. Or if they were done, it just kind of led to data, but then that data just kind of sat there and didn't lead then to action. And so we know that as a profession and as a genetics field, we really need to provide some additional research projects that focus on this issue around inclusion, around how to help minority genetic counselors really reach the levels that they deserve in the workplace. And then
Barbara,
Yep.
sorry, we have about like 1 minute before we get.
Okay, gotcha. Yep.
Okay,
Yes,
thanks.
that's no problem.
Oh, yeah.
So on our last couple of slides. So we, as is traditional in African cultures and has kind of bled into the African American culture, we always look to our ancestors and look to our past as ways to learn and how to base our actions in the future. And so just to acknowledge that as we were forming Golden, we did look at programs that were successful in getting minorities into STEM fields. And so Grace alluded to this a little before, but and the people that we selected, but also looking at the Howard University Genetic Counseling Program, which was in existence up until about 2014. UMBC has a very successful STEM program that Grace actually experienced as an undergrad. And so she definitely pulled on that as we talked about the mentorship aspects of our program. And then, right along the same time that Golden was being formed, just a few years earlier, the Minority Genetics Professionals Network was established. And it really has been a phenomenal resource for us and partner for us in engaging this conversation and engaging folks in this conversation around genetic counseling as a career. And so as we go to our last slide, we recognize that we are standing on the shoulders of work and individuals that has gone on before us. We very recently, as a Black genetic counseling community, really reconnected with some of the first Black genetic counselors. We actually had a Zoom call and it was just amazing. But we met Dr. Lorna Wilkerson, who came through the Sarah Lawrence program in the early 80s. So her and another Black genetic counselor who was a couple years after her, we sat down with both of them and really reflected on how things have changed and not changed so much, as demonstrated by this quote that she provided in a 1985 article that was in the Journal of Genetic Counseling. And so I won't read it here, but just to say that, some of these same issues are still here, but, Golden is here to try to address those. And with all of you here on this call, we hope that together we can make a difference. And so with that, in the chat, hopefully we'll pop in a collaboration sign up sheet. So whether you want to collaborate with Golden specifically, or even with each other, we know that this is not a one woman or one man or one person show. It really is going to take all of us to move this needle. So I think that's in the chat. And I'm done. Thank you.
Thanks so much. That was a really great session. So thanks to Dr. Gold, Grace Ann, and Barbara for a really informative session. I'll give folks a second to get to that form if you want. And again, I learned a lot. I thought that was really, really good. I think we have time for questions. Social media shout out for sure. But I think we'll all go and watch your YouTube channels. If you have questions, you can send them along to us and we'll try and get them answered. And I think our time is up here and we're going to have to be jetted back to Zoom 1.